3 or 4 days of ICU was really a knock on the door and come back.
I remember that year 2016. In many ways, you have been an example which has transformed cancer care for all of us. And when we saw the PET scan, we were so amazed. All that cancer had just melted away. It never happens in kidney cancers. But we said, look at this, it's right in front of us.
We are always thankful to God for giving me a second life.
Every pet is normal, and today it is 10 years. We proudly say it's a decade of immunotherapy. You encourage people to know that this can be fought, at least potentially we can fight it. Hi, I'm Dr. Amit Rauthan. I'm a medical oncologist from Manipal Hospital, Bangalore. And today I'm in conversation with a very, very inspiring person, Mr. Mahesh Seshadrinath. He's a long-term survivor of kidney cancer, but he has a very, very unique story, and it's a very inspiring story. So it is wonderful to be talking to you today. Hi, Mahesh.
Thank you, Doctor. Nice meeting you also. And it's always been a pleasure to be with you and get your advice now and then.
So it's been a long journey, and please tell us, how was life, about your general life, your profession, your family, the whole story before the journey of diagnosis of cancer?
Well, let me introduce myself. I am a retired professional, engineering professional, as you already know, working for a manufacturing company. I was, we're working in Bangalore for almost about 20 years in a corporate atmosphere and leading a normal life with a family. Towards 2007, I had to shift to Mysore for my professional reasons and went to a greenfield project, which was a Japanese multinational company. That's when it was at the cusp of 2007, 2008, when a lot of things started changing for me. Initially, I had cardiac problems with stenting of my iliac and my artery. This was in 2009 and 11. It was a normal life. I was shunting between Bangalore and Mysore because my family remained in Bangalore and I was basically single in Mysore. Around 2015, I started developing a chronic cough, which was what the first indication was. And then suddenly, it led to a lot of diagnosis, and each one led to finally that I had a tumour in my kidney. And so that's where in 2015 February I was diagnosed with the tumour, a partial tumour, and then so we had to do a partial nephrectomy to remove the tumour. And there it started. Initially the doctors were quite upbeat. They were saying that it should not be a problem later and that most of the affected parts has been removed. But the biopsy which came later on after the surgery showed that it was renal cancer with rhabdoid feature, and so that the protocol used to be followed. So every 6 months we had to do a scan. And that after 6 months, September 2015, is when we did the first scan after the post-kidney nephrectomy. And we found a small spot and looked like a recurrence of the disease. So one thing led to the other, and by the end of the year, I was again back on the table, and my left kidney was sacrificed. And I had a total nephrectomy. And later I was told to go and follow up with a medical oncologist to take it further. I was at that time under the treatment of hospitals. And then subsequently we were looking around and we had a lot of consultations and opinions were sought from a lot of leading oncologists. At that very time, in that juncture of a month, I started getting a pain in my back spinal cord. That was quite worrying, and so we went to meet a doctor, spinal cord specialist in Vikram Hospital, now Manipal, earlier Vikram. And to our surprise, we did a scan and we found that the disease had spread actually to the other organs. And we were immediately said that there was no option of any surgery at that stage. And they said this has to be treated only medically. So this happened somewhere in Jan 2016. And we immediately started looking for specialists. And that's when, as we zeroed in on yourself, Dr. Amit, and I should be thankful that you were there to help us out at that stage. That's where our journey together started, perhaps. 2016, January, I remember that my wife and my cousin sister met you, and then we were told to start on the oral therapy, sunitinib. And at those 3 months, that went away with what was not at all effective, and it made things worse for me. And I was almost like a vegetable, not able to move, not able to drink, not able to eat. And that's when we were rushed into Manipal ICU, and I had a horrendous 3 or 4 days. Somehow came out of it and came out of it.
It's a very, very exceptional journey. I cannot imagine the whole situation of you were doing the most difficult things before, traveling from Bangalore to Mysore every weekend, living, and then with this diagnosis and this impact, it must have been really, really tough. How did the impact affect you, your family? How did things?
Well, as you said, when I was in Bangalore, working in Bangalore, of course, I enjoyed the family life. I was bringing up, my son was doing his schooling. But when I shifted to Mysore for my professional reasons, when I joined this new company, I was forced to leave my family behind, and I was forced to stay alone. Okay, initially you have that josh of staying alone, and you have no... but I used to be a weekend or they're coming back home to Bangalore. But later, especially when this setbacks happened, it became very difficult for us. The family was concerned about my health, and I was concerned about how I'm going to take care of myself. Mysore had still not developed to handle that kind of medical care, and so I had to depend on my Bangalore. And I also had this professional headache on me to take care of this new project. I was heading the operations over there. So all this was a big dilemma. But then I took it step by step. So that's when we started with sunitinib first. And then it became worse, unfortunately. And those 3 or 4 days of ICU was really a knock on the door and come back situation.
Yeah, it was very, very scary. I can tell you, your dates which you remember, I remember equally well in every time I say, because I remember that year 2016. In many ways, you have been an example which has transformed cancer care for all of us, and especially in India, I would say. I can tell you why. I can tell you those dilemmas we had. A kidney cancer stage 4 post-surgery recurrence, it is usually a very, very life-threatening disease. We had discussed this earlier. The only treatment we had available at that time was the tablet sunitinib, and that was the best tablet for it. And we had given it to you, and we saw in 3 months the cancer just progressed and spread all over. And the disease was spreading in the liver, in the peritoneum, in the bones. And then with that ICU stay, I think it was a very, very tough time. I remember sitting with your wife, talking to her and telling that
what next?
What next is a very difficult question to answer. And we had conversations, but you were in the ICU, and we had conversations saying we may not have much to offer, and we've come to the end of the road where there is not much treatment available for kidney cancer which has progressed on sunitinib. There were these tablets called everolimus which we wanted to try. And then that year was so significant for us because 2016, this new drug, immunotherapy drug, got approved by US FDA in the US. And that drug was called nivolumab, and it really changed our perspective. We had never even used it. We had never heard of it. It was just we had started hearing about this drug. I remember your wife asking me, saying, why didn't you give it a try? I told her we haven't used it. We haven't seen it. It's not come to India. And she said, so what? Get it. If you can get it and try. They was talking about why don't you fly down to the US, but that was impossible with you in the ICU that you could fly down anywhere. And that was such a transformative journey.
I understand.
We had just read about the drug. We had read how immunotherapy can unblock the immune system and to fight cancer cells. And for that, for us as medical oncologists, it was so different from concepts. We were attuned to chemotherapy, where we give medicines which kill cells but also kill normal cells and have side effects. We had heard about targeted therapies which were like sunitinib for kidney cancer. We blocked pathways, but immunotherapy in 2016 was a very, very novel concept. I was amazed at you and your family. They actually put in and said, get the drug, whatever the cost.
I presume I had the age in my advantage at that time. And of course, being in my early 50s, nobody wanted to leave me. The family wanted me as eagerly as everybody would like to have their male figure in the family. Anyway, so I'm quite happy that the family persuaded you and you were able to suggest that medicine at that stage. So there are a lot of things like you hear about it, you learn about it, but you were able to start with me. And that itself was I think a great step from your side. If not for you, I don't think we would have even tried that drug till now.
Correct. In many ways.
Somewhere we had to start, and you were a trigger for that.
In many ways,
very
in India,
thankful for that.
In India, you were one of our first patients who took chemotherapy in kidney cancer in India. So that's why it was very unique. And the other side of it is, when we just gave 3 doses. You had imported the drug at a huge cost, and we gave just 3 doses at 15 days. And when we saw the PET scan, we were so amazed. All that cancer had just melted away. We could see it clinically new. You were getting so much suddenly better. And that PET was so amazing that my nuclear medicine specialist asked me, what are you treating? Is this kidney cancer? We've never seen such responses in kidney cancer. They told me, this happens in lymphomas. It never happens in kidney cancers. But we said, look at this, it's right in front of us. And then that dramatic journey changed. I again think 2016 was a significant year for us because we started your treatment in early 2016 or mid 2016. And the drug officially got launched in India at the end of 2016. And that's where the costs came down a little bit compared to earlier.
I understand. We didn't have to import.
We didn't import the drug, and then we were able to give it to you from the regular point. And then the whole journey transformed. 1 year of immunotherapy was an amazing experience for us as oncologists.
It was indeed an emotional ride for all of us. We also saw it was a miracle for us. So it was definitely a miracle, God sent, and we are always thankful to God for giving me a second life.
Yeah, it was amazing.
It was definitely a miracle for us.
What we didn't know was, would it respond? Would the response last? What happens? How long to continue? We didn't have any answer.
Exactly.
And we said empirically, just go ahead, and I remember you telling us, just do the PET scan and see what's happening, and keep doing PET scans. We'll keep doing it and watching it.
In fact, we reached a stage, if you remember, I asked you, sir, next dose if I take, I'll be in the streets. So that was how we were continuing. We didn't know where to stop. And,
Absolutely. Yes.
And my finances were running down, and it was a dilemma. I mean, I'm thankful it's all behind, and
I can tell you a clinician's dilemma. We didn't know whether works or not. We didn't know whether it has side effects or not. We didn't know how long to give immunotherapy. But it was such a learning experience, but such a wonderful experience for us when we saw you getting better, continuing. And then that whole decision which we took together, that let's stop at 1 year, let's not continue this indefinitely, and let's keep watching the PET scan. And it's been so amazing. We are doing your PET once a year, every year, and every PET is normal. And today it is 10 years. We proudly say it's a decade of immunotherapy, and it's all because we've learned how to do it in many ways from your experience.
Of course, apart from mine, what I've been following through the years now. Why? Because the fear of recurrence always is there for me. We always, my family or me, or when I talk to my colleagues, we always bring up this subject at some phase anytime during our conversation. The fear is that, what next? Whether we are, totally free from it and all those things. So I also understand that immunotherapy is still not a sure shot therapy, and it still is almost a 50-50 chance, or perhaps a little more. I don't know now.
I think a very pertinent point in immunotherapy, because so what happens is that when we see these positives, we actually think it's going to help work with everyone, and that's not reality. The way it works is it unblocks our immune cells, our own T cells, and we hope that those T cells kill cancer cells.
Right.
But there are various situations which happen. There are patients where the T cells just don't get unblocked. They don't kill the cells at all. There's sometimes no T cells there at all to kill cancer cells, and sometimes the cancer just gets resistant and grows wildly. So we have, over this last 10 years, we have used so much immunotherapy in so many different cancers. We started with kidney cancer, we started with melanoma, we moved to lung, we moved to head and neck cancers, we moved to a family of tumors called MMR deficient cancers, we moved to kidney cancer, stomach cancer, bladder cancers, endometrial cancers. You name the cancer, immunotherapy is going up the ladder. But we are clearly seeing that it works very selectively. So there are patients which will show dramatic response, and there are patients where it will just not respond. And we are learning that we don't know all the answers. We really don't know how to choose. We don't have biomarkers. We have a couple of biomarkers to say this is a patient who may respond, but we still don't have any biomarker to tell our patients that you will have the same response which Mahesh had. But again, why I go back to this is, I have lived through the chemo era where we have seen cancers like kidney cancers where survivals were so short once they progressed on sunitinib. There's nothing worked. Patients who progressed on sunitinib, we gave them everolimus, and after a few months, most patients did not pull very long. Unfortunate story. So we learned that immunotherapy can work, and it can give us sustained long-term response like yours, at least in selected patients. But you are very, very right. We have seen failures. We have seen many patients where it's not worked, where the story is not the same. And that is the reality of cancer care. What it is also teaching us is how to combine immunotherapy with other things, how to improve our responses, how to make sustained responses. But yes, we unfortunately see the bad side of it also.
How do you choose when to start or whom to give immunotherapy?
So in most cancers, what happened was immunotherapy started off as late line, like your story, where you moved through what was standard of care and there's nothing to offer, then you offer immunotherapy hoping it will work. But now immunotherapy has moved in the upper lines. So in kidney cancer, it's become standard first line therapy. And now in kidney cancer, even after operating the kidney, we say adjuvant immunotherapy for a year may help. In lung cancer, it's become first-line therapy. In many cancers, it has moved up the ladder. But unfortunately, it's not consistent results. And we keep seeing that every day, We keep hoping we'll see one deep, sustained response, and sometimes we just don't see it. But we have a pool of patients now. Like you are a decade of immuno for us, we have a pool of patients in lung cancer, in other kidney cancers, where we have now patients who have crossed many years. And by many years, I say 7, 8 years, 5 years. For us, this is a long, long period for stage 4 cancer.
Right.
But yes, we have to learn a lot more about immunotherapy. We also are learning the other problem, the side effects.
Mm-hmm.
In rare patients, the immune system gets overactive, and with that reacts against the body, causing any autoimmune reaction. And that worries us also a lot.
I'm an example for that. My diabetes got kicked up because of this. I was never a diabetic patient until that stage. And overnight, I became diabetic.
We see hypothyroidism also is very common post-immunotherapy. And then there are these other rare side effects which can be really problematic. Luckily for us, it happens only in 10% of patients, but it could affect any organ in a bad way. We have to be very careful and cautious when we use it. We have to use preventive measures, and we have to catch them early. So it's not all good, but it has definitely changed the perspective of cancer care. I keep reiterating once why is because they are our own body's T cells, and they have memory. And if they have memory, they can have sustained long response. That's why seeing your response gives us a lot of encouragement when we talk to patients. But yes, we also see the other side of it where it doesn't respond, and it can be a very discouraging story in cancer care.
So what I was wanting to ask you always was, should we take again any preventive care of doses?
Yeah.
Just to keep the T cells alive, or whatever, in your terminology.
We really don't know the answer. So I can tell you today, when they wrote in initial immunotherapy protocols in 2013-14, they actually chose those stage 4 patients who had very short survival, and they thought, we don't know whether they're going to live very long or not. Let's make an immunotherapy protocol, and they didn't know how long to write it. So they wrote empiric protocols. So most protocols chose 2 years, saying let's give 2 years, we'll see what happens. And it was so surprising when 30% of patients started living longer than 2 years. And these patients who respond to immuno can have long responses, and then they didn't know what to do. So there are protocols which say give continuous immuno, there are protocols which say stop immuno at 2 years, and then there are protocols like yours where we say just give 1 year and stop. If it comes back in future, unfortunately we hope it doesn't happen, but if it happens, maybe we will restart immunotherapy. Again, there's no right answer there.
So nothing preventive as such.
No, I don't think so.
The sword is always hanging for me as far as I am concerned.
I know that's the most difficult part for a cancer patient. I hear this from all patients telling us, that
The recurrence is very
unpredictable recurrences. And so we tell patients, don't worry about it. We tell, no, don't worry. But I know as a patient, you are the one going through it and you will always be thinking of it. And there's no way a patient stops thinking of, once a cancer patient will always keep thinking. There are different cancer patients all around in the society, and the way the cancer populations has gone up, there'll be different stories. And some people in stage 1 equate to stage 4 stories and they get worried, though mine is coming back. We tell us early stage, chances are very less, cure is good. Late stage, things are different. But it's very difficult in our society because all of us are hearing stories every day.
I myself may have recommended quite a few patients to you to come and see you. I don't know whether it's immunotherapy is going to work, because they have also heard about the therapy. So they come to me because I'm a living example. And then I say, I am not sure whether it's helped, but you can go and meet Dr. Amit. They come back saying, no, he has said it may not work for them. As you rightly said, I think it's still in a 50-50 chance and how we are going to take. But is there any other therapy which is developed in the years now?
Yes. What's happening with the immune system is you are trying to learn why does the immune system doesn't then get unblocked for some patients and doesn't get active. So they're using combination of 2 immunotherapies. That's one option. Secondly, in some cancers like lung cancer, they give chemo plus immunotherapy. So chemo kills cells, gets the immune cells there, gets the T cells, and that immunotherapy unlocks the T cells. That's the hope of it. There's combination of immunotherapy with targeted therapies, and now there are a lot of new targeted monoclonal antibodies, we call them. They're monoclonal antibodies to certain targets in cancer cells, and they have combined chemotherapy combined to it. They're called antibody drug conjugates, and they are being combined with immunotherapy, but all of them are kind of evolving, I would say. We still cannot say stage 4 consistent response with anything, and that's where the dilemma is, the hope versus the chance it will not work, and that's something is a very difficult balance.
Do I have to worry about this genetically possibly going down my line?
So there are certain cancers which are proven to be hereditary, where they are proven genetic cancers, like when we say early stage breast cancer, triple negative breast cancer, early age ovarian cancer, early age breast cancer. These are cancers where there is a very strong hereditary link, and these are known that you can do a blood test, understand which is the mutation, or like a BRCA mutation, and then you can check the whole family looking for who carries the abnormal gene. They have to take special precautions. Those who don't carry the abnormal gene, they don't have to really worry too much. In kidney cancer, there are some syndromes, but they are very rare. They're not very common, and you don't seem to have that mutation. Otherwise, there would be a multiple link in the family of young age cancers or different types of cancers. I don't think you have the genetic link, but yes, these days we have guidelines which say that if there are multiple cancers in the family, or if there are multiple types of cancers in the family, we have to test their blood. We send their blood for what is called as hereditary cancer testing, and if it comes positive, then we have to take certain precautions, and we also have to test the siblings, the children, the whole family, and draw a family tree.
Oh, okay.
I know I always get excited when I talk about immuno because we have seen the good side of it. But tell us how the other impacts to it, the drawbacks to it which you faced when you took immuno.
My side of it, as I said already, it was 2 things. One was the diabetes. The second one was my guts. I had a lot of problems with my gut movements, if you recall. I had to do a colonoscopy to check whether some problem was there, and then they ruled it out. In fact, I was talking to Dr. Raj Vignesh recently. He was saying, I remember you were the first case to come as a side effect of immunotherapy. So that was only 2 things, and the gut thing has somehow sort of settled down. I don't have any issue on that. But yeah, I'm a diabetic patient and I'm on drugs, so that I don't think that can be reversed. Of course, I need to do a lot of lifestyle changes, which I am not ready to do right now.
Right.
Thanks to my various problems and this.
The other impact, the one which, the big elephant in the room, the finance.
Oh, that of course, as I said last when I mentioned to you, well, when I came to the last dosage, I did plead with you, doctor, if I have to do the next one, I have to be on the streets. But yeah, of course, it drained a lot. Those days, immunotherapy drug was imported. If you recall, I had to do 3 dosages per treatment. And yeah, it costed me a lot. It drained away all my savings. But somehow I coped up after that. The life has been good. I was able to do a couple of more years of corporate life after that, which helped me recover some part of it. And my earlier investments, what I had made, my savings, that helped me survive. But this is where I was trying to, tell you also that the insurance companies need to do a lot for cancer survivors. The cancer survivors are always treated as aliens by the insurance companies. Once it's cancer, there's no insurance for me. I came out of the corporate insurance. I did not continue with my own insurance earlier, which was a big blunder I made. But that's not the case for all. But nobody, thinks about these things at early stage. But now, of course, the awareness is there. I'm sure a lot of people have a change in their thinking. But during my time, Gen X, if you can call it, we never thought of all these things to occur. And so yeah, it was very difficult because I was not at all covered. And even after my survival, I was not able to get a decent insurance policy only because I am a cancer survivor. So I think your fraternity should help us in this way to at least talk to the policymakers of India, insurance policymakers, and tell us that we are not aliens. We are also human beings, and they should definitely encourage people. I mean, it's so expensive. So this is another thing which always worries me. Recurrence is not because of going through the pain or whatever. It's more of the pain of the financial strain also. Multiplied effect which has on patients, especially survivors. And even for the new patients, whoever are going through that, it's the amount which is given by the insurance company, they treat as though you are cheating them. The minute you go with the cancer, they feel that, you're cheating, you're not covered, you're not doing this, that. That aspect is definitely a very big mental strain on the survivors and the patients. So during the patient stage itself, I'm talking about. But yeah, so now I think people are thinking different and covering themselves much more with higher premiums and this one. But there needs to be some relook at the policies.
Absolutely. I can tell you when we talk to cancer patients every day in out, their worries, their questions are always based on, one is potential to cure, am I going to be cured? Second is side effects. But the major discussion also is finance, and that's the whole impact it has. What is the impact it's going to have to my family? And many patients in advanced stage ask the same thing is, if I don't live through this, if I'm going to spend a huge amount and I don't live through this, what is my family going to do? And these are so difficult questions to answer. It also creates a dilemma in my mind when I talk about an expensive therapy with that hope that it may work. Am I going to drain away more finance? And we keep deliberating this every time. But that hope is there, and you want to give that hope because you have seen the successes in certain patients. But you have to also be realistic. I can tell you one thing which has changed in India, which is really very good, has been the cost of immunotherapy has tremendously come down, is because of a lot of patient support programs by various companies. Though all those companies who brought Immuno into India created patient programs. I give this example because we have lived through this. So what you paid for one dose was what now patients are paying for a year of immunotherapy, which is amazing because the patient programs have been made in such a way that you can buy some immunotherapy for 5 doses or so, and the rest of the year is free of cost.
Oh.
So they made very aggressive patient support programs.
Well, that's nice.
So that's very, very encouraging, and that's the reason
that's from the pharmaceutical side.
That's from the pharmacy company side, because they are also wanting to expand the use of immuno. It's going up so hugely that everyone wants that every cancer would have immuno in some line of therapy. So that's one thing which is good, which has happened. But yes, the other bad side which you have spoken about is a very difficult question. So we have faced this situation where We have written the immunotherapy when patient has told us, oh, we have a insurance coverage which is good, which will cover it. When they send the papers, it doesn't get covered. And because they did not have the modern medicine covered in their insurance policy, so that's all this awareness is coming with time. And I fully acknowledge your thought about all cancer patients post their diagnosis need some form of coverage which has to be done. It has to be there.
Some assurance, mainly the assurance.
I fully agree. And I think this has to be taken up in a very huge level. It has to be from a lot of patient group initiatives, a lot of doctors initiatives, and a lot of people have to take it with the government and the insurance agencies. And I think this is required because we are saying on one hand, we want to cure cancer, we want long survival, but on the other hand, we know you're not going to be covered, and that's not going to be a realistic view. These are a lot of evolution in cancer care, I would call it, but it's been a journey of learning, and it's been a journey of hope, but also a journey of realistic learning, not saying that everything can be good. We know some things can be good, some things can be bad, but we have to go through the journey, and you have taught us all this so much.
Whenever we think, people ask what next, I'm just leading a retired life, so I'm happy that I'm not able, I don't strain myself, stress myself. I'm not doing any consultation work to get my cases working or any such thing, but I'm sure people other than me are in the cusp of continuing their work, and there are so many people in the middle age who are affected nowadays. And that's what worries me, that how are they able to continue after the survival. And so for looking at the future, do you think there is going to be much more therapies and sciences going to change?
Yes, I think so.
Or are we still stuck in one place? No.
I think science is evolving dramatically.
Because chemotherapy we are talking about for the last 30, 40 years. And now immunotherapy is now 1 decade. So we are still not come to a 100%.
No, I agree. So we always say this, probably the cancer cells in our body are the smartest cells and the smartest thing in the world. The way these are our own body cells, and the way they evolve with time, and they cause resistance. We gave chemo, and they became resistant. Now we gave immuno. Yes, some people are doing well, but others again are resistant. We got targeted therapy. They are probably the smartest cells. But what I find very encouraging is the way we are looking at it. Earlier we used to say blindly, just kill all cells. Now we are looking at precision oncology, where we say, find the target, find the mutation which is driving a cancer, and no two cancer patients are the same. Look at lung cancer now. Lung cancer for us, adenocarcinoma lung, whenever we see one, we take the biopsy, send it for what is called as next generation sequencing, and we find 10 different subtypes. It could be EGFR, ALK, ROS, RET, MET, HER2. We call them different subtypes, and all of them have different targeted therapies. And once we identify them, there are patients with a type called ALK. With oral tablets, patients are surviving decades just with oral tablets with stage 4 ALK positive lung cancer. We can get there. But yes, cancer cells are very smart. They keep mutating, they keep changing. But the science and technology which we have now is kind of encouraging us a lot more. Find the target, block the target. Find the target, add the immunotherapy. Add in more things. I'm sure we will keep fighting this. Yes, stage 4 cure is the toughest thing, and that's probably not going to be an easy thing. We are going to get better with time. That's great. It's been really wonderful.
Yeah, I'm very happy that we were associated, and we are still associated.
I know.
Continue to be coming to you for, every annual PET scan. I look forward in January.
Absolutely. I really like it that you've gone out and you tell your story. And there are a lot of patients I tell, some don't want to tell their story for various reasons, which is always, there's always issues of privacy, and I don't want to talk about it. I don't want to go through that whole journey in my mind again. It hurts a lot. But I really am encouraged when I see you talk about your story. You encourage patients. You encourage people to know that this can be fought. At least potentially we can fight it. Now what the results are, time will tell us. But there's that hope, and I really like this about you.
Thank you.